This conference will now be recorded.
So today is a teaching also for me. First of all, as we all know that there are anxiety, depression, and psychosis on which we will be focusing more, and because this anxiety and depression, they constitute the most common problems in pregnancy. So there are nice has suggested some questions to screen the depression during pregnancy. In pregnant women we need to ask the three woolies questions. So the mnemonic is DDU. Do you feel down? Do you feel down, depressed, or hopeless during the past month? Have you been bothered by having little interest? That means uninterested. Just excuse me for a minute. Yeah, sorry. So, this is down, depressed, or uninterested. These are the Woolies questions. So, you'll be asking for depression screening. So, you should be knowing about that. So, in history taking as well, whenever there is we always ask mental health assessment is done by these questions only, as we all know that in mental health history, it is mandatory to take in all pregnant women, right? And for mental health assessment, there are particular questions. Do you ever feel down, distressed, or uninterested in the surrounding in past couple of weeks or in past month? Okay. And then there are some scales. If the Uli's questions, it comes as positive screening, then we put them through the scale checking, that how much score they are having in the postnatal depression scale, that is the Edinburgh postnatal depression scale. And there are patient health questionnaires as well. These are the self report questionnaires. The papers are being given to the woman, and she being asked for marking the columns in which she is feeling like the scale consists of number of questions, um, 10 or 15 questions. So in that, if scoring is being given by 0, 1, 2, 3, so and after that score is being calculated. So in this scale, as we can see here, the depression severity can be assessed, that patient is in depression or not. So we do the screening with Wooley's questions, and if she's found positive, then we put them through the Edinburgh depression scale or patient health questionnaires number 9. It is a multiple choice questionnaire, and rating is being done not at all is 0 several days. Like if you're being bothered, do you feel weak, or do you feel lazy in getting up? So if the answer is no, then it is 0. If yeah, on several days I feel like that, or more than half of the days in the past month. Okay. And nearly every day is 3, more than half of the day, or half of the days is 2. So depression severity is being calculated by these numbers, and less than 5 is no depression, 5 is mild, 10 is moderate, 15 is severe. So the range consists of 5 to 9 mild, 10 to 14 moderate, more than 15 is severe. So you may get the the station in which you'll be given the papers, and the you just don't have to mess with the understanding of those papers. You just have to see how much scoring has been given in the bottom line or on the side, wherever it has been calculated. And by just seeing the scoring, you have to categorize the patient in mild, moderate, or severe condition of the anxiety or depression. For the anxiety, there are GAD scoring, so that is generalized anxiety disorder scale, GAD 2, GAD 7. So this is on the number of questions asked. And anxiety screening scales in the GAD 2 scale: do you feel nervous, anxious, or on the edge? Are you not being able to stop or control worrying? So this is GAT 2, and GAT 7 is having all these 7 questions. And again, the scoring will be 5, 10, and 15. That's mild, moderate, and severe anxiety, respectively. So, when used as a screening tool, these are the depression scales, these are the anxiety screening scales, and Uli's questions are the depression screening questions. Okay, so anxiety screening are GAT 2, GAT 7, depression screening are Uli's questions. And now, when used as a screening tool and you find that patient is having moderate anxiety when the score is 10 or more, then this is the threshold. Further evaluation is immediately warranted in these patients. Now, there are some red flag signs which you should all know in the perinatal mental health. Red flags for suicide and psychosis. In this situation, recent or rapidly changing significant alteration in mental state, which is a sign of psychosis as well, and emergence of new symptoms, which can include psychotic symptoms or severe anxiety in relation to her infant. So, delusion or hallucinations, if she is developing, this is a red flag sign. And if she has anxiety in relation to her infant's welfare, psychotic symptoms that involve the infant, thoughts of violent self harm or suicidal thoughts, either thoughts or acts, both are red flag. Okay, and new thoughts or persistent thoughts or non reassurable ideas and expression of these ideas when the woman believes that she is incompetent as a mother. Okay, or feel estranged from her own infant, and she has those confirmed ideas that no, I am not a good parent, good mother, I will not be able to take care of the baby, or just take that baby away, I don't want to take care of the baby. Pervasive guilt and hopelessness, that's also a red flag if it is persistent. Then deterioration in function as a consequence of symptom, self care, care of the infant, avoidance of the infant. Patient is not eating well, not sleeping well, psychomotor retardation. Okay. Okay. So now there is indication. There are set of indications for referral to perinatal mental health services. You should all be knowing that, because these are very gross, so you can remember that easily. There are some gross indications. If a see on first encounter when woman comes to the consultant led unit, in that situation, if woman has a current symptoms of psychosis, severe anxiety, severe depression, okay, and even if the screening also suggests that it is she is having moderate anxiety and she need to be evaluated further, and if the team thinks that no, she need to see the perinatal mental health team, in that situation. And if you feel that patient is neglecting herself, the clothes are not well worn, and speech is not clear, or there is some features, if you find that patient is suspicious of having a mental health problem, but you need to exclude all the organic causes as well, and harm to others or significant interference with daily functioning is there, then you refer the patient urgent basis to the perinatal mental health services for further treatment. And women who has a history of bipolar disorders or schizophrenia, women with previous serious postpartum illness, puerperal psychosis or severe depression, postpartum depression, um, woman who is having complex, who is on complex medications or the psychotropic medication regimes. Okay. And there are few indications in which referral is considered, like in moderate severity if developing in late pregnancy or the early postpartum period. If there is illness of moderate severity, moderate anxiety, moderate depression, um, in that situation also patient can be referred to postnatal mental health services. Women with current illness of mild to moderate severity, where there is first degree relatives also with bipolar disorder or puerperal psychosis. Why? Because they have a higher chance of having the problem, who have a history of first degree relatives affected with mental health problem. So, if you combine the history also and present condition is suggesting that the mental health problems have started, then she should be seen by the perinatal mental health services or perinatal mental health team. There is a very good talk because in RCOG they have set some questions that how the woman should be asked, because there is a too much of dilemma for the mental health now also. So there are some questions which has been given in this talk that you can ask the patient on first interaction in a way that she should not feel offended or she should not feel ashamed as well. So some set of questions are there, and how you can help them with they have concluded the nice guideline points as well in terms of how what help you can offer on the first meeting, or in the um, when the patient come to you in the maternity care. The things to be assessed in first contact with the pregnant woman, you need to take significant history of the woman, mental state examination, risk assessment, and you need to give her information and safeguard the woman. So these are the things which you have to see in the pregnant woman, and this talk establishes all these points. In history taking, there is a particular psychiatric history as well, which they have given in these tables. Patient's mood, anxiety, psychotic symptoms, the questionnaires you can give the woman and check that, and past psychiatric history, present psychiatric history, whether she is on any medications, what how this problem is affecting her, does she has any support in the family, also does she has any first degree or second degree relative who has this illness, anybody had is in her family, is there anyone who had done suicide or ended the life by suicide, or has she herself thought of any harm to her or to others, how are her relations with the partner, does I mean, if she's already diagnosed, then ask about partner's mental health as well, and about the domestic violence as well you need to rule out, and what social support they have, how is the financial status, is she having any other children, and if they are there, then how is she able to cope up with the situation, is she able to take care of the children or not, and does she smoke, any alcohol, any drugs history, this is very important, and how was her childhood, was it a pleasant one or not, and apart from that any abuse history, how is the family structure, Is it like, how is the relationship between her parents, and is it a happy family? How about her sexual relationship with her husband? And like, what about her education, what about her job? And any time has she been, even this is important, that because of these mental health, has there any been any issue in which you get convicted, or anytime have you been contacted by the police, or things were that bad sometime in your past life? And depending upon the situation, you can ask these questions. How would other describe your personality when you are well? This is a very important question. So what, how is her pre-morbid personality? There's also we need to check. And her medical history is very important. Apart from mental health problem, does she has any other problem also? Because we may these symptoms may overlap from the if she has any autoimmune problem, any cardiac, any any other systemic problem. So the symptoms may mimic depression symptoms as well. So we need to be very much we need to be careful in separating those. Mental state examination also, there are some points, like you have to check take I mean, these are few points under which you can describe her mental state. You can write down in your notes by seeing her appearance, her behavior, her hygiene, her speech, whether she is making eye contact or not, how is the speed, are you able to understand what she's speaking, and is speech is relevant or not, whatever she's talking, is it a relevant talk, and is she able to speak confidently, or she is uncomfortable, and how's her mood, like, is she happy with you, is she it's like, if you are a like, mood is affect, so it is a subjective feeling. And but you have to record it in an objective way, like whether she was feeling low, whether she was okay, or it was a mixed, or she was excited, however was it. And was the emotions changing, was she in a depressed mood, or she was crying, and how was her reaction on your talks. Then thoughts also, does she having any disturbed thought content in the form of hallucinations or delusions, or is she seems to be obsessed with some thought, and is she having obsessive compulsive behavior? How, whatever, you have to ask the questions in those way. Does she ever have thoughts of self harm or harm to others? And how about her memory? Is she able to focus? Is she having any memory problems? Is she oriented to time, place, and person? And does she perceive what she is feeling? Does she know that she is not okay? Because perception and insight, this is the main differentiating factor between depression and psychosis. If insight is lost and abnormal behavior is there, this is psychosis. A depressed patient is having insight. And you have to record the history points. Now there are some key points, like how to ask and how to help. So in those, some beautiful lines are there, like you establish the repo, and you can talk to her in a way, that I know opening statements are there, exploratory questions are there. So whoever woman comes to you, you can ask the person or the woman. Generally also we have to ask, and if you are suspicious of having mental health problem, then you can be even more empathetic in asking that, I know there are uh, many pregnancy is difficult. It can be the most difficult stage, because so many hormones are getting released, and it puts some stress on your brain, that sometime you may think what you don't want to. Generally you are okay with these thoughts, but some thoughts may trouble you when you are pregnant. And you may get some different thoughts also, which can make you sad and uninterested in the surroundings. um, and there is no shame in discussing all that with your doctor, because we can help you in a better way, and nowadays a lot of help is available. So may I ask, does any thoughts are swinging in your mind these days? Okay. um, so like this, you can ask her. There are a set of lines given in these talks. You can pick up any, you can make your own words, and you can ask. And once a rapport has been established, then you have to check her mood. Like, how has been your mood recently? Any concern, any anxiety? Do you feel more support can be helpful for you with with upbringing of your, in taking care of your child? She may have children and she may find it difficult to manage them. Then you can ask that, how are you coping at the moment? Are you able to sleep well? Are you able to eat well? How are your energy levels the whole day? Are you able to find enjoyment in routine things, or in the things you were enjoying before? Do you still find them enjoyable or interested? Have you had any unusual experiences recently? Is there anything going on which you want to discuss with me? And 4% of the women require inpatient treatment and should be admitted to a specialist mother and baby unit. These are the MBUs. Total 17 MBUs are there in UK in the different areas. These units are currently funded centrally by the Specialist Commissioning Board. Members recommend that admission to a MBU should be considered where a woman has the following. So there are some there is a list which you should be having, because it can be asked in the viva, and this is very important. And in the case also, like some family member can come with the, with the symptoms which you have to correlate, and you can advise them that we need to admit this patient, admit her as soon as possible or immediately to the mother and baby unit, where the baby can also be taken care of. The beauty of MBU is that the bonding between mother and baby is not disrupted, and baby can stay with the mother. So the indications are rapidly changing mental state, which is a sign of patient may go into psychosis, suicidal ideation, particularly of a violent nature, in which it is harmful to leave patient at home or in the general hospital, pervasive guilt or hopelessness, significant estrangement from the infant, new or persistent beliefs of inadequacy as a mother, evidence of psychosis. So these are the indications, okay? And what are the contraindications? That can also be asked sometime, or you should know when the patient is severely, like, she's too much violent. She's into psychosis and she is getting too violent that it is harmful for other people, to other women, to stay with her. She can be harmful to the staff, she can harm the other mothers as well. So we will not keep her in MBU. Pervasive guilt. Mhm. um, Apart from that, if woman is severely depressed, severely, I mean, patient is having violent behavior, in those situations we will not keep her there. And now, nice guidelines. What are the highlights? How you can advise the woman who has mild anxieties or low mood? So in those women, you can tell them that that sleep hygiene you can maintain. What is the sleep hygiene? We can help you in certain ways. We can advise you on a few things which you can inculcate in your day to day routine life, and you will find that they are really helping you a lot. First thing is, uh, there is a set of few methods, we call them sleep hygiene, which if you follow, that helps in keeping your mood up, like walking and going to bed at the same time, waking and going to bed at the same time every day. If you avoid coffee, tea after 5 p.m., or in the evening after certain, after your evening tea, if you stop it and don't take coffee in the night, take some hot drink, hot chocolate while going to bed, before going to bed, you can read in soft light. Just try to avoid screens, mobile screens, televisions after 8 p.m. and or just 1 to 2 hours before going to bed, and sleep at a reasonable time. And if you can try some breathing exercises or meditation before sleeping, that will help. Then, if she is having hyperemesis, then you can advise her to have small regular meals, hydrate yourself, take ginger based tea or some biscuits along with the tea. Don't take tea alone. And regular antiemetics, which are safe in pregnancy, you can take that. Importance of regular gentle exercises is to be told to the patient that they release some chemicals which are happy chemicals. So if you exercise on a regular basis, it helps. Then, encouraging self reflection on a particular anxiety issue. Tell her about writing a journal if you can start writing, or if you can, there are online journals also available. You can write in them every day, make a routine, and this helps. And sometimes self reflection or seeing into what is bothering you, it really helps. Signposting to services in the community, definitely tell her about, there are special support groups in the society I can put you in touch with, where you can do exercises together, that you can do meditation together. There are a newer concept of mindfulness as well, where they just ask you to be aware of your surroundings, and that also put a lot of, release a lot of happy chemicals, and you find yourself really elevated. So those can also, that can also be done. And yoga techniques also are there, which makes you, make your pregnancy journey also comfortable, and as well as your mental health also improves. Swimming classes also, they help in releasing endorphins, which are the good chemicals. So they can help. So individual guided self help based on the principle of CBTs. So you can tell them about the CBTs, that there are some talk therapies which are available, and you can do it by yourself. There are CBT apps available, and or one to one cognitive behavioral therapies are also available. So we can book your meetings with the counselors and they can help you. In the nice, what else is there? Though there are many things which you know already. I know that you all know, because those are simpler things and these are day to day things. So the numbers are, which has been given in NICE, are depression and anxiety are the most common mental health problems during pregnancy, with around 12% of women experiencing depression, 13% experiencing anxiety at some point. Okay. So, depression and anxiety also affect 15 to 20% of women in the first year after childbirth. So, this is about the percentages. Postpartum psychosis, this number is very important. 1 to 2 in 1,000 women who gave birth, they can be affected by postpartum psychosis. Women who are having a history of bipolar disorder, they are at particular risk. Okay, or who have a first degree relative with bipolar disorder, they are also at risk. So, and in eating disorders, binging is incidence of binge eating is higher in pregnancy. One should always advise women to stop smoking and alcohol during pregnancy, because it can lead to, or it can increase the threshold of relapse of mental health problems, or they can appear as well. So, and it also causes prematurity in IUGR and fetal compromise with these substances. Now, according to UK marketing authorization, no psychotropic medication is recommended for women who are pregnant or breastfeeding. So the prescribers should follow relevant professional guidance. So it should always be, medication is always be prescribed by perinatal mental health team. It should not be prescribed by us in the pregnancy. Consideration for women of childbearing potential, use of and who are having mental health problem, existing or past. Tell them to use contraception till the time they are on psychotropic medication. If they are on valproate, um, tell them that this is harmful if you conceive for the baby. Do not offer valproate or acute or long term treatment, either acute or chronic mental health problem. Never offer valproate to a woman of childbearing potential. This is important to know. And principle of care in pregnancy and postnatal period, it should be a coordinated planned care integrated care plan should be made for the woman who is pregnant and having mental health problems. Now you see the spectrum of postpartum mood is there: postpartum blues, postpartum depression, postpartum psychosis. That's all there. Most common are the blues, then the depression, and psychosis is not common. It is 1 to 2 in 1000. Postnatal blues, what are those? You need to pay attention that it happens during the first 3 to 10 days postpartum mainly. Okay, it can happen in first 2 weeks. Women may experience low mood or mood lability, means sometimes excessive cry, tearfulness, anxiousness, irritability that can come. And it is very common. It affect almost 50 to 80%, means almost all. So last for approximately 2 to 3 days. Peak on day 5 postpartum. It is the peak day. If it happens before that, symptoms are mild, self limiting, and will require reassurance and monitoring. So, just think about that. That we need to ask about the sleep, appetite. Mostly it is not disturbed. Okay, self harm thoughts, any abnormal thoughts, they don't come. Basically patient is tearful, and sometimes they are postpartum and fear of being a new mother, or pain, or the labor itself when it ends, it can cause stress on women. So this is a stress reaction, postnatal blues, and you just need to tell her that just sleep well, eat well, drink well, and you will be fine. And it can be, you can recover from it very soon, and we all are there to help and support you. So it needs reassurance, and but we need to be monitoring the patient quite closely, so that the symptoms does not aggravates and she does not go into depression. Okay, so the treatment of postnatal blues is reassurance. Now perinatal depression. Depression is up to 30% of women. uh, they can be affected in the postpartum period. It is a common problem, and up to 40% have a risk of relapse also of the depression. In severe depressive episodes, psychotic features may present. So what will happen in depression? Persistent sadness, low mood. Okay, the patient is persistently sad. She does not have any interest in the surrounding, or she's not happy basically, and she feels tired, energies are low, and the sleep may be disturbed. There can be poor appetite, the thoughts can be aberrant. She can be the movements can become slower. She can be uh, guilty, or she may blame herself if anything happens to the baby, or if feed is not coming, if she's not able to feed, or if she's not able to take care of the baby, she'll keep on blaming herself, and her functioning is not proper. What are the risk factors? So there is a long list, and I think mostly we know that history of psychiatric disorder, history of postnatal depression, family history of psychiatric disorders. There is a history of childhood abuse, substance abuse, domestic violence, any chronic systemic illnesses. Young age young age is a risk factor for depression. uh, Unplanned pregnancy, single mothers, poor social financial support, preterm births. Preterm birth is also a risk for perinatal depression. Increased parity, if too many children are already there at home to take care of, that is also a risk factor for depression. Low birth weight of the baby, migraine, migration status, if she is not the native, that also put a stress about the well-being of the child in future. Sorry. Postnatal depression affects between 10 to 15 in every 100 women, with approximately 3% of deliveries in them severe depression can develop. Okay, now gradual onset happens in first 2 weeks after childbirth. and two peak presentation is there. Whether she will present in first 2 to 4 weeks after delivery, depression can mostly occur, and then 10 to 14 weeks post delivery it can happen. Okay. Women with a history of major depression and a family history of postnatal depression, they are more likely to experience postnatal depression than those with a history of major depression without a family history. Okay. So same was in the psychosis, same as in depression. If a family history is there, things, and she personally also had the problem in the past, then it is quite possible that postnatally things can come up again. Study shows that greatest risk period in women with a family history is thought to be first 6 to 8 weeks of postnatal period. Okay. So 6 to 8 weeks. So that period 2 to 4 weeks, 10 to 14 weeks, like the first 3 months are difficult for the woman. Risk associated with untreated depression in the when she's pregnant. This is we are talking about that. And spontaneous abortion, lower gestational age, lower infant birth weight and low APGAR score. Patient may develop pre-eclampsia even, neonatal intensive care unit admissions and breastfeeding initiation problems. Mild to moderate depression, what is the treatment of mild to moderate depression? In mild to moderate depression, refer the patient to local psychology services, also known as IAPT, or primary care mental health services. Okay, mild to moderate will go to primary care mental health services, where they will be offered low intensity psychological input. This is basically CBT only, cognitive behavioral therapy, in which there will be 9 to 12 weeks course will be there, and some 6 to 8 sessions will be there. It can be face to face, it can be online. Okay, so that you can offer uh, primary care mental health services referral and low intensity psychological input as the treatment of mild to moderate depression. Moderate to severe depression now depends upon the individual. It varies, but the options can be high intensity psychological intervention, means CBT will be there, and it will be more frequent for more duration and by the experts. And pharmacological treatment will be select SSRIs, SNRIs, or TCAs. These are the medicines which can be given for the depression treatment, or the combination of CBT and the medical methods. And now these psychosis, see, the percentage is important. Psychotic disorders include bipolar, schizophrenia, schizoaffective, and psychotic depression. If she is having severe depression with the symptoms of psychosis, women with a history of psychotic disorder have an increased risk of postpartum psychosis. Approximately 20 to 30% of women with BPD will develop postpartum psychosis. 20 to 30% of bipolar disorders. Now, they will be referred to perinatal mental health team, and they also, moderate to severe depression also will be referred to perinatal mental health specialist team. And women should be offered preconception counseling with a specialist. Late meeting in the pregnancy will also be taken place, and multidisciplinary team will be there. Sign and symptoms are many. It progresses very rapidly. Once a patient goes into psychosis, she doesn't give much time. Within few hours the situation deteriorates too much, like hallucination, delusion, fear, perplexity, confusion, agitations become too much agitated, mood become labile, the speech is not clear, she is distracted easily, rapidly changing mental state is there, which we call kaleidoscopic presentation. That is rapidly changing mental state. Onset is usually early in the postnatal period. Okay, 50% of the postpartum psychosis happens by day 7. Okay, sometimes it can be the early sign of labor also, when the women start behaving differently and in a psychotic way. That can be like in the antenatal period, that can be a start of labor. Now, how to diagnose and how to manage? When you diagnose by the symptoms, yeah, so you have to admit the patient. Okay, urgently get a psychiatric assessment done. She should not be left alone. She should be provided with the medication, that is inpatient, admit to MBU or admit to, if MBU is not nearby or full, not having place near, not having MBU near your place, then the hospital consultant led unit or maternity specialist care admission can also be done, where the access to psychiatry services is available. And antipsychotic medications are started. These sometimes they may require mood stabilizers and antidepressants as well. Puerperal psychosis is particularly responsive to ECT, that is electric convulsion therapy. Now coming on to the prognosis, this is important number. Up to one in every two women, they have risk of recurrence of puerperal psychosis. I don't know why these slides have been shattered like this. So okay, and the the studies which were previously showing that if we put them on to prophylactic doses of lithium or olanzapine, but now the evidence is that they are not beneficial actually. So recurrence risk is the same even if you put her on the prophylactic medicines. Hmm. Elective admission to a MBU may be required. Follow, suppose if woman is having postpartum psychosis, and we have read this, that this is an indication of admission in MBU as well. Postpartum psychosis history. Support, there are different, like when you do the SPT, then you can tell the women that there are many charities, mental health support groups. There are Tommies, there are Mind, and maternal mental health alliance is there, which can help you and provide you support 24 by 7. These are some, I found it on the RCOG website. These are the maternal mental health, separating the myths from the facts. So it is just data on which this is being given, that how many percentage of the women think this and what is the fact. 32% did not realize that healthcare professional could help, and this is the fact. So myths and facts busting is done over there. 28% felt that this is the stigma, there is a stigma attached to mental health problem. 28% felt embarrassed about talking. 27% thought it was normal to experience mental health problem. Okay, and these are the facts given in these that in that infographic, that you can talk anytime. 23% were unsure what is wrong, and 23% felt their clinician were unapproachable. So how we can improve our communication with the patient. And then coming on to 19% were not asked if they were experiencing any mental health problem. So that's quite a high figure. 13% were worried about the way they were feeling. Okay, so that was all about theory I wanted to discuss in brief with you guys. um, so now there is a case, and if anybody wants, we can make it more interactive if somebody want to participate. Hello.
This
is so
conference will now be recorded.
this is a high risk pregnancy. So as she is 14 weeks, so I will
Mhm,
take the complete history to assess the severity of symptoms and rule out the risk
mhm,
factors for her previous depression. As she has a past history of depression, she has a strong family history of depression and psychosis, and she is on antipsychotic drugs as well. And her gait score is 7. So in view of all these high risk factors, uh, uh, during the antenatal care, I will involve my consultant and
mhm,
perinatal health specialist team,
mhm.
neonatologist, and involve the counselor and support as well.
Mhm.
So,
Okay.
mm, as she is 14 weeks, so I would like to know whether this is her planned or unplanned pregnancy. And was if this is unplanned pregnancy, so which contraceptives she was taking, and in the end I will give her reliable contraceptives. And moreover, um, and she already stopped her medicines. So I would like to know her reason of stopping the medicines, why she stopped her medicines. And I will encourage her to continue her medicines until she get the opinion from mental health team, or um, her doctor related to depression.
Mhm.
And I would like to know if she is having any eating disorders, sleeping disorders. How is her behave with the surroundings, and whether she harms herself, and rule out hallucination and other warning signs if she is having. And I would like to know about her down screening, and her detailed scanning would be done at around 20 weeks.
Mhm.
I would like to know how old is she, and which parity is she having. So in this way, I will assess the need of aspirin as well. And
Mhm.
at around 20 weeks, she should have uh, detailed scanning to rule out congenital anomalies which are associated with some antipsychotic or antidepressant medicines. And these patients, they are at the babies are at high risk of IUGR, preterm delivery, preeclampsia, and baby can be having the same condition. So there would be vigilant monitoring, and uh, it each visit we will inquire about warning signs, and det- um, and there would be regular scans after 24 or 28 weeks versus the growth of the baby. And uh, and I would like to know if she's having enough support at home, how is the partners behave, and uh, and the aim would be for normal delivery if there are no complications with her, or with her baby at the time of delivery. During delivery, she will be giving enough painkiller. um, Epidural would be would be ideal if there is no contraindication related to same, and there will be continuous monitoring of the baby during them. This is intrapartum care. Shall I
Yeah.
continue?
Yeah. Yeah,
So
yeah, sure.
during
Next question is, how will you plan her intrapartum and postpartum
so
period?
yeah. And even during antenatal period, at each visit, we will assess for the need of blood thinning agents. And during intrapartum, she needs enough support, and one-to-one monitoring, and we will involve the perinatal health mental team in her delivery as well. And there will be continuous CTG monitoring along with enough adequate pain relief medicines. As there is a high risk of psychosis after delivery, in that case, that is almost 50%. And we'll monitor her, and moreover, she is at risk of high blood pressure as well, and diabetes. So we have to, and during antenatal period, we have to rule out her diabetes by screening at 24 to 28 weeks as well. And moreover, she will be giving mm, medicines to avoid postpartum hemorrhage. There will be active management of third stage of the labor after delivery. There will be enough support for the patient. We will help her in breastfeeding, give her reliable contraceptives. We will assess the need of her admission in in mother baby unit if it is required, and we will involve our team related to the psychosis and depression. And she insists for the admission of the baby. In that case, baby would be with the ma'am. Shall I proceed to postpartum care? Yeah.
Yeah, yeah.
So yeah.
You're
So
already
during
there.
During admission, the baby will be with the patient, but there would be one-to-one support and one-to-one care with the help of the specialized midwives and specialized nurses, as there is 50% risk of postpartum psychosis. And she will be giving the medicines if need arises. And yes, ma'am. And I will provide her information leaflets, number of support groups during antenatal period, and give her reliable contraceptives after the delivery.
Good.
Thank you, ma'am.
What are the indications of admission to MBU and when can it be done?
Yes, ma'am. Admission is needed if a patient is having new thoughts, if she harms herself, or if she has loss of interest in her surroundings, and mm, and it is needed even before delivery or after delivery.
Okay.
Hallucination and mm, patient having previous history of MBU unit with warning signs, we will admit.
Okay, fine. I think that's all about the questions. Mm, yeah, yeah, that's all. Just give me a minute. I'm giving you feedback. You did really well, Shaista. Um,
Thank you, ma'am.
just hello. Yeah. Okay, Shashta, you did well, very well. I mean, you have covered many safety points, but there are few things which I would like to tell you. I think I should give the key answers so that you will also know what you have missed. But what you have included is also very important. Like, but there are like you said that baby may have same condition, so that's not correct. Baby, if she is on some kind of antipsychotic medication, then there is a risk of having neonatal adaptation. That baby can have, but not the mental health condition. And apart from that, you covered the serial growth scans, antipsychotic medications. And I always tell every time I tell that, you need to check the station very well. Like, she had a history of postpartum depression. Okay, her mother is suffering from bipolar disorder and she is on antipsychotic medicines. So always on your notepad you can write the main important points so that you don't say it in your viva or in your spts. Some wrong correlation you don't make. Okay,
Yes, ma'am.
so she was on antidepressant medicines, and I would like to inquire what kind of medicines were they. I would like to review her notes, okay, to see. And GDM you covered, because when patient is on on psychotropic medications, then she is at risk of developing diabetes, gestational diabetes, and screening is important. So regarding that you spoke, but you spoke in the second questions, and I'm
Yes,
not sure if the marks will be given in the antenatal
right.
answers.
Yes,
But you covered it because you know it. So with practice you will be able to put it in the antenatal part, I am sure. And apart from that, yeah, you said continuous CTG monitoring. Though there is no indication for that in the mental health problems, but yes, according to hospital protocols, the monitoring will be done. Okay. Pain
Right.
relief, it was a good point. Breastfeeding, we will promote for breastfeeding, but if any medications is there on which breastfeeding is contraindicated, like on lithium, then she will be advised not to breastfeed, and breast milk suppression will also be given to help her. Take care.
Yes, ma'am.
Fine. And
Yes.
then MBU, yes, assessment will be done. Contraception, you said, even VTE risk assessment, also, you said. So, those were very, very good points. MBU admissions, that has a criteria, which I've already told you. So, just pick those points, remember that, and speak up, okay? Just point wise you go and speak. And when can it be done? It can be done from 32 weeks to 32 weeks of pregnancy till 1 year postpartum. Okay. So
Yes, ma'am.
that can be done in this period, 32 weeks pregnancy period. After that, anybody who had severe depression or psychotic features, or she is having self-harm thoughts, or she is having past history of postpartum psychosis, or severe depression with family history of postpartum, with family history of mental health problems, which raises their chance of developing psychosis, in those we can offer them admission, and 32 after 32 weeks of pregnancy. Somewhere it is written 34 weeks as well in NHS, but mostly 32 weeks is the correct answer, and till 1 year of delivery. Okay, if
Right.
woman has any indication till 1 year, she can be admitted in MBU. Now coming on to the key answer. Hello.
Yes, ma'am.
Yeah, you want to ask something? You were saying something?
No, no, ma'am.
Okay. So in this, coming to the key answer, like, uh, hello, I am Shaista, and I am the candidate for MRCOG Part 3 exam. I have read the scenario and I'm ready for the discussion, as we say, right? Even if you don't say, it's okay. In this patient, okay, how will you proceed for the antenatal care? In this patient, my concerns here are, the patient is a late booker. She has come at 14 week. I would like to know why she has come late. Is there any was it an unplanned pregnancy that has not been diagnosed, or there is a domestic violence, or there is some abuse is there, or she is having a severe mental health condition which is bothering her. On her GAD scoring, this is a moderate anxiety, I can see. So she needs urgent referral to the perinatal mental health team. I would like to review her notes and her medication, which she has stopped already. So this puts her at increased risk as well. So, and also I would like to put her in touch with the counselor. She's off medicines. That's also a concern. It needs to be restarted as soon as possible with the help of combined efforts with perinatal mental health team. Um, she has past history of postpartum depression, which has 25% risk of recurrence, but she has a family history also of bipolar disease. So the risk even increases more to 50% almost. So she's a very high risk patient for the mental health problems. Um, I need to mention this in her notes. And the care will be provided by the team. There will be maternity care team, there will be specialist perinatal mental care, health services, which will be her hospital team, and there will be community care team also need to be set up for her. The proper channel need to be set up for the management of women. In community care team, there will be GP, community midwife, social services. In that, health visitor will be there, and a care coordinator who will coordinate all her care between the teams. Now, for managing her antenatal health, I would like to gather some more information regarding her past treatment and relevant history of this present pregnancy. Was it a planned or unplanned? Has she taken folic acid during this time? Any investigation, booking bloods or scan which has already been done? I would like to screen her for GDM because she's on quetiapine. It has been written. That is psychotropic medication, which puts her at increased risk of having GDM. So it should be screening should be done at the first visit itself. Then as she is coming at 14 weeks, if no combined screening has been done, then she can be offered the quadruple test, which can be done between 16 to 20 weeks, and the anomaly scan. But I would first like to confirm the pregnancy and the gestational age through the ultrasound scan if it has not already been done. So that is to be arranged urgently. Um, and past pregnancy, as she has a history of postpartum depression, I would like to know her parity. How did she deliver? Was there any complication? What was the outcome of the delivery? Um, what about her mental health? Were the symptoms controlled in the past pregnancy and after the delivery? Or it aggravates, or ever she was admitted in the MB unit or in any hospital during the pregnancy or after it, or in between the pregnancy periods? Is there any other systemic illness which can aggravate the symptoms? And is there any family history? Though she has a family history, um, but how is the family member, the mom, is coping up, and what kind of symptoms does she have presently? And does her symptoms affect her, whether they are living together, or how can she be able to cope up with the stress of her mother's situation as well? How is her partner? How is the support system? Any other medical problem that we have already discussed? I think I've repeated it. And smoke, alcohol, drink, any drugs. Then do the risk assessment, which you have done. Harm to herself or any thoughts of suicide or to the baby, and any domestic violence. Does she feel happy and safe at home? And any abuse in the past? What is the trigger for her mental health condition, which is depression? What was the trigger? Is there any surrounding factor? Is there any past related to that that we can ask, and we can do the risk assessment? Examination, yes, I would like to measure her blood pressure as a routine as well, and as the mental health condition may put her at risk of having high blood pressure during pregnancy, so I would like to check it at every visit also. Her weight to height ratio, routine ANC blood test and scan for fetal well-being. uh, MDT involvement, consultant led unit. I would like to put her electronic notes, which can be put her details in the electronic notes so that it can be assessed anywhere and quickly. If even if she comes in the emergency, handheld notes will also be provided to the woman, and partners should also be told about that. Details of the symptom and treatment and the treatment. I would provide them with the crisis contact number, and if you have told all these things before, no need to speak it again. That quadruple test, anomaly scan, risk of FGR, serial growth scans will be done. You have told that, Shaista. And additional visits will be there because this is a high risk pregnancy. Medicine review, we have already told. There will be a late pregnancy meeting in which we can plan her labor and delivery, in which hospital team, her partner, community team, all can be involved. Uh, Family member and partner should be made aware about the symptoms of going into severity of the disease. She may need MBU admission. Uh, Documentation and written information is provided to herself and to her family members also. How will you plan her intrapartum and postpartum care? I think I missed VT risk assessment here. That also you can speak. How will you plan her intrapartum and postpartum care? She is a high risk pregnancy. Hospital delivery is to be done, multidisciplinary team care, continuous midwife support during labor. Review her medication. Always you will review. If she any medicine case, any patient who is on medication, review her medication in labor, review her medication in post delivery, involve the team who has given her medications. Monitoring of patient and the baby according to hospital protocols. CTG monitoring will be done. Baby should be observed for neonatal adaptation syndrome after the birth. In postpartum care, continue the monitoring. Single room near nursing station will be better for her. Medication review, because she will need a good sleep and she may get disturbed with the in the wards, and sleeplessness is again a risk factor for the disease progression. Medication review by perinatal mental health team in postpartum care. Suppose if a patient in this intrapartum care, I'm coming back to it. If patient is on lithium, we need to stop lithium during the labor and delivery. So that is why reviewing medication, if it is written that if she is on lithium, then you have to speak that we will stop the lithium in during pregnancy and labor, during labor and delivery, because increased amount of lithium crosses the placenta at that time, and it can be harmful for the baby. It can cause arrhythmias, it can cause toxicity. So um, postpartum medication review, if the medicine is safe in breastfeeding, we will ask her to breastfeed and we will support her. MBU admission if required at all. Family counseling will be done again when if she is going home, and crisis number will be given to her. The criteria of MBU admission, indication for that is rapidly changing mental state, suicidal ideation, pervasive guilt or hopelessness, significant estrangement from the infant, new or persistent belief of inadequacy as a mother, evidence of psychosis. Okay, am I clear so far? Do you have any of you have any questions?
Oh, ma'am, just I wanted to ask, is quetiapine an antidepressant? I mean,
Yeah, see, the same case has come in the exam, and the same scenario was there, that she was having a history of postpartum depression, and she was on quetiapine. It is a psychotropic medication. I
so
have
has
not.
it to be restarted?
Yeah.
Should it be restarted in pregnancy? Because we said like antidepressants have to be restarted. So,
According to the
okay,
safety.
the
No. See,
okay,
perinatal mental health team will decide which medication is to be started. Okay.
all right, okay, thank
Yeah.
you.
Yeah, but she should not stop it abruptly, or she should be reassured that the safer medication will be provided. But it does not, it still puts the baby at risk. Though the guidelines says that you should always tell the woman that the risk is there. Risk to the baby is there. Risk to the mother is there. Even if she continues or if she stops. If she stops, the risk to mother and baby both is there. And if she continues, the risk to the baby for congenital malformation is there. But whenever you are talking to the patient, you have to always be very empathetic, and you have to tell the pros and cons, in the sense that we strongly advise you not to discontinue the medicine. But she'll say no, but it can, you have just told me that it can cause heart defect in my baby, so why shall I continue that? Yes, but the risk of developing heart defect is really very less. And as you're already pregnant, and the drug has if it had to affect, it can affect it during this period as well, while you have taken it. And we cannot say with surety that it has not affected, but if you stop it, it will affect you even more. Risk of affecting the heart of the baby is really very less than affecting you, and you is very much higher than affecting the baby. So if we weigh it, it is always beneficial to take the medicine. In that situation only you will be able to take care of the baby, and we can screen the baby for any problem. And with the ultrasounds and with the blood test, we will keep on screening the baby with the serial ultrasound scannings. So in that way, you have to tell her not to scare and not to um, hide also, but you have told also. Okay, so both ways you have to talk with the patient. Anything else?
Thank you, ma'am. Thank you.
Okay, welcome. Now we I will take two more classes in this leisure oil group and the part 3 group. That will be on next week. We'll be talking about obesity, the newer guideline. What is new for obesity, and what does it, the incidence, and how, what problems can be there. And after that, we will do a SPT, simulated patient task, of an obese woman, how we need to handle it in exam, pregnancy with obesity. Okay, and on 6th March we'll be doing ectopic pregnancy, nice guideline. and the case of ectopic pregnancy that will also be in SPT. Okay. So these three are for sure going to happen next week and beyond that. And I wish that you all should participate actively so that I also feel enthusiastic in teaching. Okay. Um, Apart from that, I will be starting my short course that will be from 15th March. It will be 6 classes with 6 to 7 important module wise classes. It will be, and 6 to 7 cases will be there in each class. And the schedule for the classes will be given to you, and there will be once in a week class only. Uh, if we will feel that this all the topics have not been covered in these 6 classes, then the classes may I may increase the number of classes, and we will cover the important updates guidelines as well during the classes. Okay, so if anybody is interested, you can log into dovictory.org and register yourself over there only. um, Thank you, and do keep in touch, and we'll meet again next week. Okay. I will try to put this in the group, this recording, or on the YouTube, right?